Going to be doing a part of this lecture on projectile trauma, but make sure that you are going through all of the slides and following along with the reading because I'm not going to talk about everything from this section in this voice recording. So I want to do a quick overview of some of the finer points of projectile trauma analysis. So projectiles are those items that you see here listed. In most cases, when we're talking about forensic anthropology, we're probably going to be talking about firearm injuries, firearm trauma, but it includes arrows, spears, or any other kind of object that can penetrate soft tissue and bone. So we're going to skip through some of these definitions. You can go over some of this by yourself, definitions of like caliber gauge, etc., etc. We are going to skip down to what exactly a forensic anthropologist can and should look for. So looking in skeletonized remains at projectile injury is really going to be limited to a certain list of questions. So one thing that a forensic anthropologist needs to be careful of, which we've talked about many times before earlier in the semester, is the range of their expertise. So unless you have some kind of situation where an individual has specialized training in ballistics, ballistics is not going to be the purview of a forensic anthropologist. A forensic anthropologist is really just going to be looking at the range of questions listed on the slide here, so including the direction of fire, the type of projectile, and the number and sequence of wounds. So looking at gunshot trauma and bone is usually pretty straightforward. It's pretty easy, all things considered, to identify, for example, what is an entrance wound and what is an exit wound. So one thing that is really easily identifiable in a lot of these cases is the shape of the hole. So in the picture that you're looking at here, we see one of these pictures up top is nice and smooth. It's a round hole with really smooth margins. That's going to be characteristic of an entrance wound. An exit wound, on the other hand, like you see down at the bottom, is going to be a lot more fragmented. And you can see in this diagram, this little drawing, why that's true. As the bullet enters the skull, it's breaking pieces of the inner part of the cranium off and causing this kind of messy beveling around the edges of on the inside margin of this entry wound. You can also look for something called bullet wipe. Bullet wipe is basically when you have traces of metal left along the wound track. That's something that could be visible in an X-ray. So you can see here, you can kind of see it in a kind of very small way there. And also bullet fragments, which are also going to be something that you can see better with an X-ray than you can with the naked eye. So bullet wipe traces are traces of metal left along the wound track, and then bullets may fragment when they hit bone, especially at high velocity. So you could actually find pieces of metal from the bullet among the set of remains or lodged in other bones or what have you. Okay, so we talked a little bit about the entrance and exit wounds. We'll get to radiating and concentric fractures in just a moment. But going back to this question of the entry wound on the skull, you will be able to see by looking at the margins, as I talked about before, whether you're talking about an entry wound or an exit wound. So the outer table of the skull is the smooth part of the skull that you can see from the outside, the cortical bone on the outside of the skull. So that's the outer table. The inner table is the cortical bone that lines the inside of the skull. Now, you can see here in this diagram, we see a layer of trabecular bone here. That's something called the diplo. But what we're going to be looking at here is what's going on with the cortical surfaces of the bone. So on the outer table of the skull, if we're looking at an entry wound, you're going to see a round, smooth-edged hole here. So you might have, some slight irregularities We'll go back to this slide here for a second. A little bit of kind of crumbling effect on the side here, but for the most part, we're looking at a pretty smooth entry point there. On the inside of the skull, if you were to look at the inside of the skull, what you would see is this kind of messy effect here where pieces of bone have been kind of fractured and knocked out. So on the inner table, which again is this layer of cortical bone on the inside of the skull, we're going to have a bevel effect, aka internal beveling, which leads to a more irregular shape. Now, if you have if you have certain types of bullets shot by certain types of guns, you might also end up with an exit wound, and we'll get to that in a second. Now, on a real piece of bone, this is what the external surface and the internal surface look like with a bullet wound. So again, we see this really smooth, very circular, symmetrical kind of hole there, and then on the internal surface, on the internal table, we have all of this fracturing and beveling here. Okay, so if we are looking a pretty powerful gun and you have an entry wound and an exit wound. That won't always be the case if you have kind of a weak but if you do have an exit wound, you are going to see that beveling on the outer table of the skull. So you can see that here. So it's pretty easy and straightforward to identify entry wounds versus exit wounds because of the orientation of this beveling here. As it says here, the second point, often larger and more ragged than the entrance wound. That is true. If you look at the picture at the bottom, we have basically what happens when you have a significant amount of distortion and decreased velocity. So the bullet still punches out the other side of the skull, but we end up with a lot more damage for the exit wound than we had for the entry wound. And as it says here, bullets don't always exit. That's something to keep in mind if you're collecting remains. Making sure that you are sifting through dirt and otherwise making an attempt to find a bullet if it doesn't look like there's an exit wound. Variations in gunshot injury and exit wounds. So we have a variety of different types of wound shapes. We've looked at pictures of round or perpendicular entry, exit entry wounds. So we see here, this is basically when you have the trajectory of the bullet coming perpendicular to the bone. So a nice, neat, round hole. You will see something that's more oval in shape if the bullet is entering at a slight angle. You can see something called a keyhole defect, which is pictured here, when you have the bullet entering tangentially. So at an extreme angle, this is still an entry wound, so the bullet is still going in the skull, but you're seeing a much different effect than you would if the bullet was at a slight angle or coming in via a perpendicular entry. You can also have an irregular hole like you see there. That tends to happen if you have some kind of deformed bullet, if there was like a bullet that, bounced off of something before it hit the person. Oh, sorry about that. Here is a picture of what the keyhole defect looks like. So we have two gunshot entry wounds. One of them, the entry was perpendicular, so it's pretty symmetrical and round, and the other is tangential to the surface of the skull. So for the keyhole entries, you can tell the trajectory of how the bullet entered the skull because this round portion was hit first, basically. So as we can see here, the trajectory is kind of similar for these two holes. In terms of wound size, many factors affect wound size. It's really difficult to get much of a concrete idea of the type of weapon based on wound size alone. There are a lot of confounding factors and things that are just too just not very easy to pin down, basically, when we're talking about wound size relative to bullet size and gun type and stuff like that. Okay, so we're going to see some pretty predictable fracture patterns with gunshot wounds to skulls. So we have two types of fractures that are common for these types of injuries: radiating fractures and concentric fractures. radiating fractures extend outward from the entrance and exit wounds. So you can see over here where I'm pointing with the cursor, the entry wound is here, and we have these radiating fractures. If you can see it there, there's little R's drawn on the diagram, but those are radiating out from the entry point. Now, a couple of things to note about radiating fractures. As it says here, they stop at fractures already present or at suture lines. So these, as it says in the yellow text there, the later fractures do not cross the earlier fractures. So that's something, if you have multiple gunshot wounds to the head, it's something that you can use to figure out which was the first bullet wound. Because as I said before, these later fractures, the fractures created from the second wound, will not cross those created by the first. Also, these are faster than bullets, so these radiating fractures occur very, very quickly. So when we have the entry of the bullet here, the radiating fractures appear pretty much immediately. And before the bullet has had time to traverse through the skull and punch through the other side, those radiating fractures have already formed. So if for some reason you're having trouble determining which is the entry wound and which is the exit wound, you can look at these radiating fractures and figure out which ones occurred first. Now, this is not the way that this is not a picture of bone fractures, but this fracturing pattern gives us a really good example of how these radiating fractures behave. So, as I said before, you can look at the radiating fractures as clues to wound sequence. So you can figure out which fractures occurred first, and you can see here we have these two wounds, and we have radiating fractures occurring from both of them, but the radiating fractures extend much further for this top wound. And then we see on this bottom wound there are radiating fractures, but they stop and they don't cross this, this fracture that you see here. So looking at these fracture patterns, we can see that this wound up top occurred first, this fracture up top occurred first, and this was the second fracture. So the same thing would happen if we were talking about a suture. So we would see these radiating fractures stop at the suture line. So they don't jump across previously existing weaknesses in the bone. We also have something called concentric fractures, which are sometimes also referred to as heaving fractures. They occur in a different pattern than what we see with radiating fractures, and as it says on the slide here, they're produced by internal cranial pressure. So the bullet enters, the force of the bullet creates pressure inside of the skull, that pressure pushes outwards, and you have these fractures occur. So as it says down below here, low velocity bullets may not generate radiating and concentric fractures. One thing, we can go back up to this slide. We can see back on this diagram, the radiating fractures again radiate straight out from the impact point, the bullet entry point, and then we have these other fractures that are kind of circling around in a concentric fashion that are labeled C here, that are where the concentric fractures happen. So back on this picture, we can see we have this entry wound here. We have radiating fractures going straight out from the sides, and then we also have concentric fractures as well. So looking at this example, which is the entry wound and which is the exit wound, it's pretty straightforward. As I said, we need to look for the nice, neat, round hole, which would be the entry wound, which we see here. And then the exit wound, we can clearly see here, we have this external beveling. It's pretty straightforward that that is the individual's exit wound. Here's another example. This is an example in which looking at the trauma, looking at the projectile trauma, gives us an idea of both cause and manner of death. So this individual was shot twice at the base of the skull here. So we have the outside of the base of the skull. These are relatively symmetrical bullet holes. So that tells us the cause of death. The cause of death was most likely these double bullet holes to the back of the skull, but it also tells us something about the manner of death. This could not have been inflicted by the individual themselves. It definitely wasn't a suicide, probably not an accident. What we're probably looking at here is murder, or homicide rather. This is what the inside, the endocranial surface looks like for those two wounds at the base of the skull. And we can see here, this is very typical in terms of what you would expect to see with this internal beveling on the inside of the inner table. Now, if we're talking about the postcranial skeleton, we see similar types of fractures as we see with cranial wounds. Bone behaves really similarly, regardless of what part of the body you're talking about, especially with larger bones. So what we're looking at here is a diagram of a tibia, and we can see that we have a bullet entry wound here. We can also see that we have the radiating fractures, and we have some concentric fractures there as well. So it's pretty easy if you reconstruct the fracturing, you can see pretty easily what those fracture patterns look like. Here is a picture of a gunshot wound to the pelvis. Same type of thing. We see the beveling on one side and a smooth round entry point on the other. So again, everything is kind of behaving in similar ways. Okay, so when you're writing up your report, you are going to describe your observations. Again, being really careful about overstepping yourself. You are not a ballistics expert, so you can describe the location, the shape, the presence or absence of radiating and concentric fractures. You can talk about the trajectory of the bullet, which is being demonstrated here with this probe. We have a keyhole entry here, and then you can see where the trajectory of the bullet passed. We cannot talk about the caliber, so a forensic anthropologist is not capable of definitively giving a caliber or bullet type information. That's kind of out of your realm of expertise and not terribly predictable. Okay, so we'll stop here. Again, make sure that you are going through the rest of the slides. I haven't covered all of them here, and that you're following along with your book. Next up, I believe, is blunt force trauma, and then after that we'll talk about sharp force trauma.